Welcome and happy Friday, everybody. Thanks for logging on and joining us for Grand Rounds presented by the University of Washington's Department of Psychiatry and Behavioral Sciences. We have another excellent presentation for you today, but before we begin, I'd like to introduce myself. I'm Jed Thompson. I'm the Associate Director of Communications for the department, and once again, I'd like to welcome you. And while we let everyone get on their computers, I'm going to go over just a little bit of the logistics, the things you need to know about our Grand Round series before we begin. First of all, is that we are indeed recording today's presentation. People ask about that all the time. It is being recorded, and we will be posting it on our archive sometime next week. So go ahead and take a look at that archive. We've got Grand Rounds presentations going back almost 10 years. So take a look at those over the holidays if you're interested. We also are going to have a survey at the end of the presentation. So if you're at all interested in giving us some feedback, love to hear it, love to get your feedback. So go ahead and click the survey link. That will show up as the webinar closes at the end of the presentation today. We are going to hopefully have a little bit of time for questions at the end of the presentation. So if anything comes up, if you have anything, go ahead and type that into the Q&A feature. I'll get those queued up, and I'll come back at the end and we'll try to get some of those questions answered for you before we conclude. Also wanted to let you know, this is our last Grand Rounds of 2025. We'll take a little bit of a break here for the holidays, and then we'll return on January 9th when Dr. Kevin Coffey will be joining us to talk to us a little bit about his Deep Squeak project and how that's developing a better understanding of the neurocircuits involved in addiction. So mark your calendars for January 9th will be our first one for 2026. And if you want to go to the next slide here, I also want to let you all know that this is one of our Ripley Memorial Lectures. And Dr. Herbert S. Ripley was the original chair of our department, a position he actually held for 20 years from 1949 to 1969. He passed away in 1982, but now we have this lecture series to recognize him and also the work that folks are doing across broad aspects of psychiatric research. So that is why I'm really happy to introduce today's presenter. Today we have a great guest from UCLA. I am happy to introduce you to Dr. Eric Chung. Dr. Eric Chung is the Chief Medical Officer of the Stuart and Linda Resnick Neuropsychiatric Hospital at UCLA. From 2011 to 2018, he was the Medical Director of Emergency Psychiatric Services, and he was appointed Chief Quality Officer of the Department of Psychiatry in 2016 and the hospital's Associate Medical Director from 2018 to 2021. In 2019, Dr. Chung served as the first Asian American president of the Southern California Psychiatric Society. And for the past 14 years, he has served on the Los Angeles County Emergency Medical Services Commission, presiding as chair from 2017 to 2019. In 2021, he led the development of new countywide EMS policies for the management of 911 mental health emergencies, including new protocols for the care of agitated patients. So over the past decade, he has been collaborating with hospital leaders at UCLA to drive improvements in hospital operational efficiency, to elevate patient experience through shared decision-making, increase equitable access to care, and to enhance patient safety through the hospital's Restraint, Avoidance, and Reduction Initiative, which is what I believe he'll be speaking to us about today. So with that, I think I am going to disappear here. And Dr. Chung, welcome. I turn it over to you now.
Thank you very much for the introduction. Pleasure to be here with all of you at Grand Rounds. And we'll get rolling. Here we are, the title, Eliminating Restraint Use. I'm going to be talking to you about UCLA's Quality Improvement Initiative and a brief review overlay of what we will be covering today. Essentially, I wish to convey to you why we chose to go after this particular effort, what we've been able to accomplish, and how we've been able to accomplish that. We'll do some literature review and best practices along the way. We'll talk a lot about how we've had to develop our data to inform our practices, some particular efforts around focus groups with engaging staff and patients, and then our particular strategies that we've deployed that may be helpful for others who are looking to do the same. And we'll have some discussion. And I should say at the outset, I recognize that folks who are on the screen here may already be heavily engaged in activities, and I commend you for all the progress that I've heard you're making. So the title might be a little bit of a misleading title to be frank about it. We call our initiative ROAR, and it stands for Restraint Opportunities for Avoidance and Reduction. And if you notice that the term elimination is actually not within the title, and that was deliberate. Even though our hospital leadership's goal is to aim for elimination of restraint use, many discussions took place and was felt that talking with staff and talking with the frontline people who are engaged in these activities with patients, framing it as avoidance and reduction was a much more palatable approach. This began roughly 3 or 4 years ago, and our problem statement at that point in time was that unadjusted restraint rates in our hospital system exceeded comparators. We recognized extensively the risk of harm for patients and staff, and uh, to be direct, we had pretty primitive data systems in terms of tracking restraint utilization, and it had been mostly paper and pencil at that point in time of abstracting manual data out of our EMR in order to accomplish the necessary reporting. And we really had to do a lot to develop that into a more comprehensive electronic system. And to date, we had not had a comprehensive hospital-wide strategy around approaching restraint reduction, although there were small pockets of efforts that had gone on over many years in different units. There was not one that was hospital-wide. Going back to the first bullet point, I think it's really important for us to recognize that the term unadjusted is intentionally set there. Uh, Doing comparative data between hospital systems and institutions is very difficult with this particular quality element, let alone any other quality element, because in the world of psychiatry and hospital psychiatry, um, our data is considered unadjusted in that the populations are not being accounted for in terms of their complexity in the way that you would necessarily expect in other areas of medicine, where I think adjustment and case mix index is much more robust and reliable. And this is an area that I think generally as a field we have to work to address. On the right-hand side is our ROAR vision. So in a sentence here, it's to eliminate restraint use, thereby reducing trauma, maximizing patient and staff safety, mental health recovery, and equity. To give you a sense of our setting where this activity is taking place, the UCLA Resnick Neuropsychiatric Hospital is separately licensed. We are an acute psychiatric hospital, not a general acute care hospital. We are across all ages, 49 adult and geriatric, 25 child and adolescent beds. And we serve a population that's very broad, as I'm sure many of you do, with civil commitment or involuntary psychiatric detentions, eating disorders, autism spectrum disorders, neurocognitive disorders, medically complex patients within our acute psychiatric hospital, and ECT services. When we began this 3 or 4 years ago, was actually within the setting of a change in leadership for our psychiatric hospital in general. I had been appointed to chief medical officer. We had a new chief nursing officer coming on board. It was a really great opportunity for us to get together and talk about what our look at the next 5 to 10 years worth of strategic priorities would be. It also happened that we were in the process of developing a new behavioral health hospital and campus, and looking at the things we wish to accomplish prior to that move, which will occur next year. We had 4 strategic priorities that really rose to the top of the list, and they're on the screen and display. And the one in which the ROAR initiative lives is called Data-Driven World-Class Care. And that term was really driven by the idea that we wish to have data to back up and evidence that we are doing the very best we can by patients, and that we're not simply resting on our laurels or things like reputation and in U.S. News and World Report type of rankings. We would like to be able to demonstrate in true data, such as restraint data and reduction, and others, of which there are not very many in the world of hospital psychiatry in terms of quality metrics, but restraint being one of the most important ones. This became a primary focus for us. If you're not familiar with the term Hoshin Conry, it is a lean quality improvement strategy for developing strategic priorities. It really manifests in an overwhelming matrix that you're seeing here. If I trust me, if you spent enough time looking at this, you would be able to decipher it. And it is a one-page display. It's not a book of information. So within this single display, one could find the priorities, the strategic priorities, the projects that align with them, and what the outcomes are. And at the top, it's data-driven world-class care. On the right-hand side are the various projects that might be associated. And at the very bottom is the first goal we have, which is a restraint rate reduction over 5 years, aiming to have it at 0 in fiscal 27. Let me move on to give a little bit of background here in literature review and best practices. We had a multidisciplinary approach to this, including nurses, trainees, social workers, rehab, physicians, the whole gamut, and assembled a nice team to do this lit review with us and to drive the project. And we were interested in three main questions at the outset. Why should we pursue reduction of restraint use? Is it possible to do such a thing? And how have hospitals accomplished restraint reduction and elimination? And in our review of the literature, we came to understand the brief history of restraint reduction shown here, that things really kicked off in the late 1990s in a article published in the Hartford Courant with a very grainy image on the right-hand side that exposed the fact that individuals were dying in psychiatric hospitals as a result of restraint. And I believe they had captured 130 different cases that they published within their paper, which initiated a whole lot of public attention on this. By 1999, the Government Accountability Office had opened an investigation. There was activity at a congressional level in the US looking into this phenomenon. And it coincided with, in 2000, some start of grants. It actually led to the start of SAMHSA grants, 3-year program grants that we'll review some of the data of that helped to develop initiatives that would later be important for reducing restraint use. And in 2003, there was a national call to action by SAMHSA and the National Association of State Mental Health Program Directors. And then importantly, a white paper that was published between major psychiatric interest groups and organizations, the APA, the American Psychiatric Nurses Association, and the hospital associations of the other image on the right-hand side, learning from each other, which I found was fascinating because that was roughly the time that I began in my residency training, or at least shortly thereafter. And in my travels, I had not been aware that this document existed or that there was really an effort being made in multiple areas nationwide to reduce restraint. It just hadn't landed here at UCLA at that time. By 2004, a formal publication started to come out around the 6 core strategies. And in 2005, there was a roadmap published by SAMHSA for seclusion and restraint-free mental health services. So why pursue reduction of restraint? Some of this is a bit self-apparent, but to be clear, restraint utilization in psychiatric hospital settings is strongly associated with negative patient outcomes, particularly trauma. Up to 50% of patients may report traumatic symptoms or even a diagnosis that would be PTSD. It erodes the trust and respect related to between the patient and providers. It contributes to health inequities as far as the data has shown. Patients are injured during events of restraint at a rate of about 1 in 100. Interestingly, staff are injured at a higher rate of about 3 to 100, which is of particular importance to our personnel. It's associated with staff burnout, and it creates a great deal of personal ethical, and moral conflict within staff who are conducting these events of restraint. On the flip side, there's a number of benefits, including reducing everything that was harmful that was just mentioned. There's been some data to suggest that restraint reduction can help to decrease length of stay. Certainly, some suggestion that it could decrease medical costs, avoid rehospitalization. I think the data is a bit stronger around patient satisfaction and staff engagement, and some suggestion that you may have decreased medication use from avoiding restraint. Is it possible? I think the answer at a high level is yes, it is entirely possible, but each hospital may have approached it in a different way. One of the culminating papers that was published out of those SAMHSA 3-year grants that I mentioned before is written here, or at least shown here on the screen. And if you combine these about 8 different facilities across 8 different states that had initiatives, at a high level, there was about a 50% reduction in restraint hours between all of them. Each of the hospital had a varying level of success, as you can see on the screen. And I'll leave it at that to say that it is entirely possible based upon this data. I think it's important to call out that in the literature, one of the papers that stands out the most is actually work done in Pennsylvania and in their state hospital system by Greg Smith and others. We asked Greg Smith to come do a grand rounds at UCLA about 3, 4 years ago when we were initiating this. And really, at the high level, they ended restraint use in 2015 and have not used it since then. The paper on the left shows the initial work from 1990 to 2000 with some reduction in the rates from 3.5 to 1.2 events per thousand patient days. This was one of the first papers to outline some effects related to age, where younger patients were having more restraint events and older patients were in restraints longer. Some effects related to race and ethnicity, higher rates and longer duration for patients in minority race and ethnicity, and then some effects around timing and staff injuries. So I think it's a impressive feat that they have accomplished, and one of the most outstanding articles written in this area of restraint and seclusion reduction. By no means are they only one. Are they the only one? There's been a number of different other papers written. Here's just a sampling of it. And our purpose in doing this part of the literature review was in part to help convince our own folks here, our own staff, that we may not be as unique as we think we are. That just because we take care of what we think of as unique populations, child and adolescent, older age, geriatric dementia patients, patients who are involuntarily hospitalized. Um, Overall, I think we had a sense that we were telling ourselves a story, as in our patients are sick, therefore they require restraint. And this gathering of data and information was to help to make the point that this can be done in a lot of different settings, and that we would be able to confront things that we had been telling ourselves for a long time, and begin to change that culture. I'll culminate here in terms of the background in that there are a few different published strategies around how to reduce or eliminate restraint. But this one stands out to me as one of the most organized and one of the most clearly stated. And it's called the 6 core strategies for reducing seclusion and restraint use. And the image there shows that it was uh, uh, produced by the National Association of State Mental Health Program Directors. It's not something that you can necessarily easily find, which is interesting. It's a white paper that's available, and there's some literature published on it, but it's not something that you can typically PubMed to find. And but when you locate it, it really gives you a roadmap for how to reduce restraint, or at least it did for us. And the 6 components are: number one, active leadership towards organizational change; two, using data to help you accomplish these changes. Three, developing the workforce. Four, using restraint prevention tools. Five, actively including consumers and advocates. And six, rigorously debriefing restraint events. So what I will do now is turn to some data and begin to explain to you how we've applied this framework through our quality improvement initiative at UCLA. If we took those six core strategies and put them in the orange column there on the left, and then lined up some of the activities that have gone on over the past few years for us here at our institution, this is what it looks like. And some of the key events that have gone on since about August of 2022 when we began this initiative. And I'm going to unpack this for you a bit. But this is the high level overview of the different types of activities that we've pursued. First off was getting our data straight. And as I mentioned before, we were doing hand counts, we were doing manual abstraction out of our Epic medical record system. This led to real limitations in how we could utilize restraint data. It had been primarily driven by a regulatory requirement, to be frank, that we needed to get this data reported in. Therefore, people had been doing it for a long time, and we didn't want to disrupt that workflow. At the point that we decided we want to pursue quality improvement on it, we really needed a quicker return on our data, not a 3-month data lag that it took to abstract and clean all this stuff up. Plus, we had no ability to really stratify the data based on different characteristics that we wanted to see in the patient population. So we took on a year-long task to develop that data, needing to clean up our nursing flow sheets where restraint data is recorded and, kind of the mantra, garbage in, garbage out. We needed to make sure that restraint data was accurately being inputted in the system so that we could mine it on the back end. So we improved those data input processes, and at the same time, we're able to begin validating and constructing data variables through a Tableau dashboard. And so now on the right-hand side, you can see what we're capable of doing, at least a brief description here. We can pull key metrics of restraint rates, seclusion rates, IM injection rates. We have a special dashboard that can show us outliers, which I'll talk a little bit more in a moment. We have some key variables. This is just a sampling: unit, age, diagnoses, social drivers of health, gender, race, ethnicity, payer, social vulnerability index, housing status, primary language, sexual orientation, and more that we can use to really get deep into whether there are particular populations that are disproportionately affected by restraint utilization. This is a screenshot of what that data dashboard looks like. The restraint rate by count on the left-hand side, the duration or utilization in minutes, both reported as rates per 1,000 patient days, and all the different variables just to give you a sense of how we can use the drop downs to select the data and show us different displays. So not to bury the lead, in 2022, when our initiative began, we have been trending in a roughly 12 events per 1,000 patient days. It can be the rate can be reported in different ways, but we use 1,000 patient days here for our standard. And we were at about 12 events per 1,000 patient days. And in the first year in 2023, we had a reduction of over 50% to about 5.6 events. And at that time, I thought this could be anything. This could be a fluke. This could be simply the Hawthorne effect. But by the second full year, we were down to 3.8 events per 1,000 patient days. And thus far, 3 quarters into this year, we are now at 3.1. So for an overall reduction of about 75% from baseline. In terms of duration, this is a slightly different picture. Baseline is still 2022. It's interesting that our restraint duration was very high going back 5 years, 5 to 6 years now, and has been decreasing since that time. And that we are now seeing a little bit closer to a plateau in our current data. It's a 64% reduction in minutes per thousand patient days across all ages in our hospital since baseline in 2022. And we're looking at an 81% reduction since 2020. When we get down into some of the details here, this is pulling it apart by adult, child, and Jerry. And this begins to tell you a little bit more of the story of unique population effects that have been going on in our hospital. The adult is the orange graphic, the orange trend line in the upper graph there. And that is actually what was responsible for that very high duration back in 2020 was the adult population. It was a peak of 24.4 events per thousand patient days, now at 4.2. So for our adults, we're looking at an 83% reduction. Child told a different story. Child had a rise in restraint use in the couple years leading up to our baseline in 2022, and a very, very rough year in 2022 with 28 events per thousand patient days. But a lot of effort has now brought it down to 3.1 for almost a 90% reduction. And last but not least, our geriatric population had a low baseline rate. That's the green line there at 2.5, now at 0.9, and very rarely used in that population. So outliers are, it's not an unusual phenomenon in healthcare, but it was very pronounced here in the world of restraint utilization at UCLA anyway. And outliers told us tell a good deal of the story in terms of the graphs immediately before. On the left-hand side, we're looking at outliers arbitrarily defined as greater than 5 restraint events during a patient's hospitalization. That's not a common definition. We just needed to make a cutoff, and that's where we made the cutoff so that we could try to better understand who are patients who have significant events over and over again. And there's not that many of them, right? On a average year, we are looking at about 1,800 admissions through our hospital system. And of that, anywhere up to 10 patients may be considered an outlier. And that those outliers had been increasing from 2020 until 2022, where we had 9 patients during that entire year who had greater than 5 restraint events. And on the right-hand side, you can see the correlated average number of restraint events per outlier, which was extremely high in 2020 at 37 events, and was also very high in 2022 with 24 restraint events on average per outlier. This is telling the story that I'm sure you're all thinking that it's a couple of patients who really wind up in situations repetitively in restraints. And in fact, these are extreme outliers in our circumstances. In 2020, it was a patient with 108 events during their 430-day hospitalization. In 2022, it was one patient with 150 events, where I think we found ourselves in cycles of not being able to move the patient, progress the patient, and get out of what seemed like um, a necessary therapeutic activity at that time and couldn't find another solution. That outlier patient in 2020 was somebody who had a psychotic illness, a young man who had the delusion that he needed to fall backwards and strike his head on the ground in order to end his life, in order to save humanity. He had done just that prior to being admitted to our hospital and was admitted with basal skull fractures that were healing. And for that entire duration, we had staff running around trying to catch him and keep him from falling, or placing him in restraint to keep him from falling. So very difficult situations. The moral of this story is that now we are looking in this year, 2025 year to date, at 0 outliers, no patients who have had more than 5 restraint events per encounter, and therefore 0 on the average number of restraint events. So honing in on the outliers has been a really important strategy for us. This is restraint rate by census race, and it shows you, again, that outlier in 2020. Can't miss the tall yellow bar at 83 events per thousand patient days. And that happened to be an individual who was African American, the one who had 180 events. So you see the disproportionate effect there. Uh, at this point, we have been in conversations with our equity officers and highly in tune with the desire to minimize inequities in care. And there are inequities over the years that can be seen in this graph. But the term targeted universalism is one that we learned is very important here, which is that if there's a population that's disproportionately affected by a particular event or outcome, as you make things better for everyone, it will get proportionally better and to a greater degree for those who are affected disproportionately. And when the bars get close to each other there in 2025, quarter three, that's the effect that we're going for in targeted universalism. That restraint rate is coming down, but it's especially coming down for those who are disproportionately affected. You see a little bit of that same effect here in the differences by gender, male blue, female yellow, and the bars get closer to each other as they approach the end of the data series. Same story here for restraint rate by homelessness status, unhoused in pink, housed in green, and some disproportionate effects that are seen earlier on and getting closer to each other as we get down to a lower restraint rate. And here it is by payer type, commercial, Medi-Cal, Medicare, and other. And I think the reason that other is a bar that is disproportionately high in this particular situation is that for some time, Medicaid, Medi-Cal insured in California, we call it Medi-Cal, was bucketed as other. And so that other really truly means indigent or Medicaid insured. By 2025, year to date, we're seeing bars that are very nice and even with each other or getting very close to that. And just one more to, I think, drive this point home. This is Social Vulnerability Index, SVI, and a higher SVI confers greater vulnerability. So that would be the yellow bars, a lower SVI, less vulnerability, and that would be the blue bars. And all bars are getting closer to each other in 2025. So we had, I've been talking to you about restraint reduction, and that was a difficult conversation at the outset with leadership was, are we going after restraint reduction or are we going after restraint and seclusion reduction or restraint seclusion and coercive measures like intramuscular injections? A decision was made by our team that we would go after restraint reduction and hone in on that. And over the past few years have said virtually nothing about any of the other coercive measures that go on in our psychiatric hospital. Not that we didn't care about those things, but that we suspected that by focusing on restraint, we would get some effect on the other coercive activities like seclusion rate, IM use. And that was a decision that was made by leadership, thinking that strategies that reduce restraint would probably be the same strategies that reduce these other things. We also were wary that in early conversations with staff, not just nursing, certainly nursing, but including some physicians, there was warning that if you go after restraint rate, seclusion rate would go up, IM injection rate would go up. And we were kind of warned by our own staff about their anxieties about what would happen. So here's the graphs. This is seclusion rate, same metric by rate, events per thousand patient days. 2022 is our baseline. We have seen a 34% reduction in seclusion rate and have said nothing about use of seclusion, but have gotten that nice related effect and looks like we're holding steady. The emergency IM injection rate was a special Tableau dashboard data build that we spent a lot of time on, and we were very interested in wanting to have good data to be able to track that electronically. We saw a reduction from 2021, which was our peak in this data series, down by about 57%, or about 30% from our true baseline data in 2022. So despite the warnings, the seclusion rate and the IM injection rate have not gone up in our hospital as a result of restraint reduction. We look at other related events or related indicators, and this is the UCLA uses Press Ganey. This is our key performance indicator for overall rating of care. We had some hope that we could get improved ratings by virtue of restraint reduction. And it may or may not be true. It's hard to tell. This is always tends to hover around an 89, 90% rating. But as it turns out, in this most recent year, we're currently trending at about 92%, which is actually a significant increase for our own institution over the prior years. We have not yet seen any type of sizable reduction in average length of stay. We tend to hover around the 14 average days for a hospitalization, and we're still roughly there. And this is the 30-day readmission rates, which I would term stable and monitoring. On the left-hand side is inpatient readmission rates over the past 5 to 6 years, stable, 8% readmission rate over the past 4 years or so. ED readmission rate has had a little bit of an uptick, and this is something that we're monitoring for. So we have some patients coming back to the ED within 30 days on a higher frequency in the most recent data, up by about 2 percentage points compared to 2022, noting that 2022 was already kind of a low point for, or a relatively low rate in this entire data series. So we're keeping an eye on this to see whether we can understand this more. Assaults on staff is certainly an indicator that we wanted to follow related to restraint utilization. This is our nursing department's mapping of data compared to the National Database of Nursing Quality Indicators, NDNQI. And on the left-hand side is rate of all assault on nursing personnel per 1,000 nursing care hours. That's the rate that they use. On the right-hand side is injury assault. So in both circumstances, in both graphs, we are the blue bar. The green is the national norm. And so you can see the delta between the two institutions. I think my summary of this slide is that UCLA had always historically done pretty well compared to the national norm in terms of the rate of assault or injury assault on nursing personnel, and that we did not see the rates go up at all. And we have seen some reductions, for example, from on the left-hand side from 0.16 to currently 0.12 in terms of the rate of any assault. And on the right-hand side, a little bit of up and down, but 0.06 in 2022, fairly stable at 0.07 currently in 2025. And we track culture of safety through institution-wide surveys, not just the psychiatric hospital. And our mean scores are in the first column here, out of 5, scoring over 4 in our most recent survey which is actually 2024, 1 year ago, but 2 years into our restraint reduction initiative. Again, folks were worried that it would erode uh, morale, it would erode culture, it may cause difficulty in staff engagement. But this scorecard is telling us actually the opposite. Our historical results or our gain over historical results are here in this column. So this is a 2024 scorecard. These were our gains over our 2022 scorecard for legacy engagement, resilience, and safety culture metrics, and our ranking as a institution compared to other academic healthcare across the country. And overall, these are really reassuring for us to see here that we did not lose. We've actually only gained engagement and culture of safety by result of this restraint reduction initiative. And something that I think a lot of institutions are tracking, we certainly are, first year turnover of staff. So new staff hired who don't make it through a year and leave the institution is very costly, very disruptive. And we had been looking at about a 20% first year turnover for our psychiatric hospital in the couple of years when we initiated our restraint reduction initiative. And in our most recent data now, we are down to about 10, as low as 6% in our first year turnover rates. And compared to our healthcare system overall, they're trending at about 29-30%, like a lot of places are. So our ability to bring in new staff and keep them here, I think, is enhanced by the restraint reduction activities. I'm going to speed up a little here so we can get through a lot of the how we did this. That was the what happened. Um, I'm going to organize these by core strategies, and actively including consumers and advocates is one of the strategies in those six core strategies. We had the benefit of having Dr. Sachs locally here in LA, who came and helped us to do the kickoff for our restraint initiative. She's, of course, the author of The Center Cannot Hold, a very accomplished scholar in her own right, and somebody living with schizophrenia who spoke very poignantly about her experience of being restrained as a patient over her lifetime. We conducted staff focus groups during our restraint initiative. We had 5 focus groups, totaling about 30 different staff to get a sampling of what people were thinking in 3 major domains. What what do you believe are the root causes for restraints being used in our hospital? What are opportunities to avoid restraint use? And what do you think are barriers to us reducing restraint in this hospital? And these are the themes that the staff came up with. They would like recognition and positive feedback for when things go well. They need help with behavioral interventions. They want to see trauma-informed care training. They are concerned about the inadvertent normalization of workplace violence. They feel that when restraint events occur, it's not necessarily as organized as it could be. They're concerned about communication among the care team. They have concerns about appropriate use of medication to address behavioral issues. They observe different cultures between staff or on different units. And they note that there may be particular moments in time where patients have more difficulty, like getting adjusted to being admitted to a locked unit or any events that cause loss of autonomy. And they identified a need for specialized treatment spaces or sensory rooms. I'll read just one of these to give you a highlight. These are actual quotes. If a family makes a complaint, we hear about it from everybody, get emails from everybody. Very rarely do we get positive recognition, and that affects morale and behavior. I'm scared because I don't know what to do to make sure to keep the patient safe. I don't feel like I have the tools to properly care for this patient when their parents aren't there. This came from a child adolescent staff person. I'm the person who is supposed to be making sure that their care is the best it can possibly be. It feels a bit like a failure on my part when I can't do that. We did the same with patients and family members. We were able to identify 9 individuals or their family members who had been um, uh, where the patient had been restrained during their hospitalization within the prior year. We asked the same overall domains of questions, and this is what they told us is important. Enhance staff-patient relationships and communication, understanding patients' needs, routines, and triggers, that more training and de-escalation would be helpful, that we need alternatives to restraint use, and that we need to consider our care environment and do things that support patient autonomy and better physical design. Just to give you a sense of one of these quotes from a patient, whenever I would have staff come in and check up on me, are you okay? Is there anything I can do for you? Do you have internet? I felt like I'm not alone. I have people that are trying to take care of me. Uh, that was a really terrible experience for me when I was in those restraints. And it depends what type of room it is. When there's like a big window, I felt way more safe, way more calm. And then another hospital, there's a small slit on the door, and that's the only thing I could see that was outside. It kind of drove me more crazy. Communication between staff and patient. I did not know what was going on at all. Maybe verbally start explaining things, visually start explaining things, anything. Any way of explaining information would have been great. I assumed the restraint event was because of this. It wasn't. I just don't really know. They kind of don't tell you much. So we had to confront these remarks from both patient and staff and sifted through them and generated a survey that then went out to all 500 of our staff persons, all disciplines, to tell us, to let them rank for us what would be interventions that are high impact and high feasibility. So 2 scores on every item. We got 130 responses, 140 responses, And it's impossible to see what's on the left-hand side, but I will tell you that things that are green had a combined score that was 8 out of 10, meaning high impact and high feasibility. And the columns that are across the top there are by discipline, by unit, by patient and family members. And it shows some uniformity, some very clear uniformity of things that are green, things that are doable in everybody's mind. And those are what's written on the right-hand side there. Improving nursing doctor communication, orienting new hires to our initiative, improving de-escalation training, debrief and reward successful restraint avoidance, and optimize medication protocols on admission. And so how we've taken those to heart. Um, this is the nursing leadership team. I give them tremendous kudos and thanks for how they have led and have gone all in on this across all different units and different disciplines. Without that, it is simply not possible. They helped us to get frontline engagement and are part of our day-to-day routine operations now, where I will show you how we are reviewing our restraint events actively. It's right here, actually. So in Care Connect, we built a dashboard that will show us the restraint events, the IM injections, the physical holds, and the seclusions within the last 24 hours and within the last 72 hours. And every morning during the weekdays, we meet at 9:30 for about 15 to 20 minutes, and we review safety and operations for the entire hospital. And it's included these events. So when a patient has had a restraint event, which is relatively rare now, we can ask the question, what support does the team need or what might they need? We're there. We can offer support, strategy, solution. Sometimes it's actual interventions around equipment that's needed, particular special needs for patients, so that we don't develop outlier patients that have 5 or more events per their hospitalization. The child adolescent unit had a particular need to develop behavioral intervention skills. This was the only FTE that we hired within the last 5 years, and it was a behavioral analyst. So a BCBA, board certified behavioral analyst, to join our team. We're not a hospital that says we do not have the capacity or capability to take care of patients with autism, but we also weren't providing support and training on how to take care of patients with autism to the nursing staff and frankly to any of the other staff as well. The idea that you can medicate away the behaviors related to autism, I think we all know that you can only get so far with that. And having the behavioral strategies and really on these patients who can oftentimes have one-to-ones, which we used to call sitters around here. They're not a sitter. They need to be active in applying the behavioral plan that is now designed by our BCBA. And this has been radically effective. We developed a sensory therapy room. Left-hand side is the very bland conference room, therapy room that it used to be. On the right-hand side, a much more engaging, rewarding experience. They can do all kinds of things now, including a functional behavioral analysis in there. And I think this is one I wanted to really highlight for you. We initiated a program called RAD Stories. RAD stands for Restraint, Avoidance, and De-escalation Success Stories. One of the core strategies for the 6 core strategies is to rigorously debrief restraint events. I'll tell you that we haven't really changed that. We keep doing the debrief that we had done, which was felt to be adequate. But what we are doing is rigorously debriefing restraint avoidance. So we have a program that is disseminated across the whole hospital with a QR code, where anytime a staff member sees or was part of an event where they avoided a restraint use, avoided a seclusion, avoided an IM, had a great de-escalation, they submit that to us, and they do so multiple times a week and tell us what worked, what was effective. And we put them in a drawing and we reward them on a random basis for that, with a little cash prize. And we publish them in a newsletter that comes out with the strategies they used. And some of the examples are here. Very simple, but very effective to remind people that this is entirely possible. Stayed calm and kind, used a consistent, compassionate tone, gave the patient space, provided an opportunity to release frustration, offered rewards, helped them to talk it out, breathe together, called in trusted staff, skipped the power struggles, focused on de-escalation, not control. These are words from the staff themselves, not us telling people what to do. And we initially, kind of went all in on trauma-informed care training. We have a very talented social worker who's a TIC instructor who's now been making the rounds and now educated a couple hundred folks across all different disciplines to really help them to understand what is TIC, why does it matter here in this psychiatric hospital, and how does it relate to restraint, use, and avoidance. So I bring you back to this. These are our activities. I've talked through most of the starred ones there as they relate to the six core strategies. I will wrap it up so we can take some questions and do some dialogue. Here's your key takeaways. We've synthesized the evidence on the risks of restraint use, the benefits of reducing it, and best practices that exist. We've reviewed an application of a QI approach that we're using here, informed by the core strategies or the six core strategies. We discuss methods of data collection and outcomes as critical first steps. We discussed an approach to engaging consumers, advocates, the focus groups we did, and the importance of leadership towards change. And we've explored drivers of restraint use, partnering with staff and patients to actively develop those interventions. Got some key references for anybody who's interested, just a sampling of the ones I find to be most helpful. And I think that's where we'll wrap.
Great. Thank you, Dr. Chung. Well, it looks like we've already got 5 or 6 questions here. We've got about 9 or 10 minutes to answer them. So I'm just going to jump right in so we can hopefully get through all of these. And I'm going to read these out loud so everybody online can hear what the question is. The first one is, hi, Eric. Thank you for this wonderful talk and hard work. I'm curious if you've had any difficulties or unique perspectives on reduction of restraint use in the ICU and critical care settings. In my experience in similar work, getting movement in these clinical settings to reduce restraints, both soft and hard, was incredibly difficult, given that they were mostly driven by critical care physician and RN staff and not usually engaged in psychiatry at all.
Okay, this question has been asked of asked of us over a couple of years now at in our hospital. So we're separately licensed acute care facility, as I mentioned, but we are highly in touch with and connected to the med surg and the ICU. That we're actually a hospital within a hospital today, so they're right around the corner from us. I understand that completely. It is tragic to see an approach where an event happens and then a patient winds up in restraints pretty much 24/7 for the rest of their hospitalization in an ICU setting or med surg unit. They just will not, they have not come up with a different strategy. The short answer is we have not been able to yet engage in a robust initiative with them, but it's right on the horizon. It begins, at least in my mind, with us redeveloping our consult liaison team to have the right resources to be able to support them. And it's not just psychiatrists, that's just one part of it. We're looking at the involvement of the nurse practitioners or hiring folks with that skill set. We're looking at proactive CL models that have been championed by Ed Lee out of Rochester. We're talking about redeveloping med psych units so that you have staff that are sensitive to and skilled and understanding of treatment of the psychiatric patient in CL settings. So I'll tell you what, in a year or two, we should talk again.
Yeah, we can have you back again next year. Why not? Okay, next question. Could you please share how you monitor inpatient readmission rates?
So inpatient readmission rates are captured and we divide it into two buckets. So it's captured electronically. We mine that from our native system. So anything that happens within our own health system, we can very easily see. So we call that domestic data. Non-domestic data, meaning we don't have really great data of a patient who gets discharged from us but may be readmitted to an ED or inpatient to a facility that was not a UCLA facility. So there's a little bit of noise in here to be sure. But it's relatively straightforward for us to be able to calculate within a patient's own identifier hits within the system in any different place. So we have an algorithm that'll say from the day they were discharged, tell me any ED visit or inpatient admission 30 days later. It's just a data logic that we've been able to develop.
Okay, nice. So quickly, one person is asking if we offer CE credits for these presentations, and no, I'm sorry, we do not for our grand rounds. Okay, next question. So wonderful talk, great work. Can you elaborate on what can be done when there are outliers? So are there any overarching strategies?
Yeah, I can say a few things about outliers. So seeing them as they're happening is key. And I actually think the awareness of unit leadership, so we're talking about unit directors, unit managers, social work leads, everybody's fully aware once a patient has had one event. When the patient has had two events, let's say 2 days in a row upon admission, we're laser focused on what's going on with that patient. A recent example is a patient got admitted. She had terrible interactions with her mother as an adolescent patient. Every time her mother is visiting, she's at risk of having an event when the mother leaves. And we got our behavioral analyst in there. We got the teams highly tuned to that because it was happening after hours. So we said we need to be very, very diligent about the strategy and about preparing for these visits with the mother so that we don't wind up developing or seeing an outlier develop here. So we see them early. We're talking about them daily. We're getting in with the primary teams, not to be, lords over them, not to descend upon them, but to ask them, what do you need? What would
Mhm.
what would help in this situation? And sometimes it's as simple as, well, you haven't consulted the behavioral analyst yet. She gets in there, she develops a massive plan. She starts meeting with the mother and begins to modify the mother's interaction with the patient so that the patient can tolerate no or separation. And we've skipped it. We don't have an outlier in that circumstance. It's case by case like that with each of them, where we can see the pattern developing early.
Great. Okay. Next one says, thanks for this presentation. There's actually two questions here. So I think maybe I'll do one and let you answer that, and then I'll read the other one. So first question is, maybe you mentioned this, but did this project end up changing the type of patients who were admitted? As in, since we are trying to avoid restraints, we won't take this patient who we would have taken before.
Great question. Short answer, no, absolutely not. Did not change anything about emissions protocols whatsoever.
Great. Okay. So then the second question is, does restraints, in quotes, in these definitions include brief manual holds for the purpose of administering IM medications? So we end up with a fair amount of kind of like 1 minute restraints for circumstances like this, which sometimes then artificially inflates the restraint numbers.
The data that you're looking at in my presentation are traditional 4-point, all limbs bound type of restraints, right? Yes, physical holds can, depending on what uh, body it is. This is actually where we need to do something as a field to clean up how we're reporting different things. Different entities require that to be included or not. Physical hold we deem as a particular intervention that doesn't have as much harm as a 4-point restraint. We watch that data separately. We can see it combined when we need to. So we have the Tableau arranged where we can see the combined restraint plus physical hold data. And we also can see it separately. Physical holds overall have come down as well. I just didn't show you the data here, but the restraint
Yep.
rate especially has come down higher than that.
Okay, great. Give me a moment here. It looks like we have a couple questions that have come in on the chat as well. Oh, a few actually. Okay. Okay, we'll try to do these. What workplace prevention de-escalation training program do you use?
So we use CIT, crisis intervention training, but we have now augmented it greatly with trauma-informed care
Oh,
and ROAR-informed data and programs that go into that. So, and we are at UCLA and UC in general about to go off of CIT. We find that it's not the right program for us overall to match this initiative, but today we are CIT.
okay, great. And then what staffing metrics should be incorporated into the restraint reduction monitoring at the system level?
This is a good question. Staffing. I don't know. I don't know that I have a great answer for you. This would be more to our nursing lead than to myself. But I can say a few things about staffing, which is that in our experience over the years prior to our restraint reduction event, the response by staff to restraints on the unit is we don't have enough staff and we need
Yeah,
more staff.
yeah,
And actually, the hospital had responded in that way in the years preceding our restraint. We added more staff, but restraints weren't going down. And then I think that's where I explain, we tell ourselves a story that our patients are just really acute, and therefore we need all this, and we can't avoid this happening. Since then, we've actually changed our staffing metrics and matrix to become less staff heavy, and it's actually been correlated with restraint reduction. We have not added staff in this nature.
hmm, okay. Okay, so one final question and we'll wrap up. Can you describe the unit programming such as groups or, sorry, can you describe the unit programming such as groups or activities used to occupy the patient?
So I'm glad we could get this question in because this is our one of our main focuses this year and now is to really do a thorough review of all the different unit programming and make sure that from each discipline's angle, we're delivering the highest level of unit program that we possibly can so that we don't have patients with extra time on their hands and bored, and counting cards. So occupational therapy, rehab, social work, nursing, everyone is doing a combined review of this. We have initiated partnerships with outside organizations as well. We have NAMI come in to do peer-related storytelling sessions. We have community groups that come in to help co-facilitate art activities so that when they leave here, they can actually go to that community organization that exists out there. It's
Cool.
an early introduction to it. We have
Nice.
folks coming in for music, all kinds of different programs that were really active in this area.
Oh, nice. Okay, great. Well, I think that's a good way to end it here to wrap it up. So, Dr. Chang, thank you so much for taking the time to be here with us during the holiday season. I really appreciate it. A lot of people writing thank you here in the chat. So, it was great having you. Folks at home, thank you for joining us. Appreciate having you. So, have a nice weekend, a good holiday season, and we'll see you again when we return in 2026.
Thank you all. Thanks for the invitation.
Bye, everyone.